Nitesh Rohatgi, medical oncologist from New Delhi. His panelists are Dr. Vikas Talreja, medical oncologist from New Delhi, Dr. Nilesh Lokeshwar, medical oncologist from Mumbai, Dr. Mohan Menon, medical oncologist from Mumbai, Dr. Ashish Joshi, medical oncologist from Mumbai, Dr. Ajay Bapna, medical oncologist from Jaipur, Dr. Amit Agarwal, medical oncologist from New Delhi, and Dr. Vivek Agarwal, medical oncologist from Kolkata. Over to you, Nitesh, sir.
Thank you. Thank you very much. Just give me 1 second. I'm missing someone here. Okay. Thank you very much. Everyone is it's great to be a part of this. Anything Amish does is always at a superlative level. And if you're joining hands with Sewanti, I guess it can't get better. I won't waste too much time in niceties, which is unlike me, but go straight to the point here. So lung cancer first line therapy, I think that was the key discussion on the cards, and what do we do in 2020? So I'll start off with a case, and I think we'll use this as an index case, but we'll keep talking about what if things were different even in this case. So 65-year-old gentleman comes to the OPD complaining of breathlessness and difficulty in chest discomfort, and there's frequent coughing. He is a reformed smoker, but reformed only about a couple of months or a year ago. He has had a dyspnea with minimal activity over past 2 months. He was ignoring it because that had happened before when he used to get somewhat symptoms like COPD, although he's not a classical asthmatic. On and off hemoptysis for past 2 weeks, which obviously concerned him, but he's otherwise quite fit well and has been exercising. A chest X-ray shows about a 4 centimeter mass in the right upper lobe. CT confirms that, along with some mediastinal lymphadenopathy and 4 liver lesions. His liver function, however, remains good. MRI brain done subsequently was negative. A PET CT scan does not show anything more than the liver and the lung lesions and a few more lymph nodes, but that was about it. And a liver lesion biopsy shows this is an adenocarcinoma, which is EGFR negative, ALK negative, ROS1 negative, BRAF negative, MET negative, and the PDL1 is 80%. So I think I have a very rich panel from Vikas to Dr. Amit Agarwal to Dr. Bapna and Dr. Mohan Menon, Nilesh. Amit certainly is there. So thank you very much, Amish, for such a rich panel. Why don't I start with Vikas first? Vikas, you're talking first line option. Do you believe that it's prime time, cause no concern for immunotherapy in first line or not?
Thank you for kind introduction, sir, and again an amazing platform to discuss. I certainly believe that IO alone is the present and is alone the future for those who are not affording no inhibitions, because A, the side effects are minimal, B, the potential option of cure in certain individuals. We are looking in terms of data of 4 years, 5 years survival, and those who benefit, they keep on benefiting for a longer period of time. So if cost is no constraint, I know Mr. Sanjay that would be on the panel of Miss Sewanti, and he would be affording that thing. So I would certainly say that Sewanti ma'am would have also agreed with me and give Pembro or the immuno a shot for the patient.
Okay, but I think I'll defer this question, and maybe Nilesh, you can take this. Do you consider immunotherapy in all patients? I'm not talking about PDL118. I'm saying, would you consider immunotherapy with or without chemotherapy in all target negative patients? Do you think it's prime time to consider that now? Nilesh?
I think with regards to the choice of using immunotherapy as a treatment option in all patients with NSCLC, this is prime time definitely.
Okay.
What matters is the combination, the choice, immuno versus only immuno versus immuno plus chemotherapy, and the various differences in a patient, like whether smoker, non-smoker, PDL1 level of that.
Yes, we'll go through all of that today. Yes. Okay. I think that makes it. Amit, Uh, I will end the day with you. I promise you that, because I know you have a new trial in design, and we will go through what should that trial entail, the 3-2-3. But in the meantime, I want your opinion on, if you were considering first line immunotherapy option, what do you make of Keynote 024 and 189? And then how does the 2279 LA fit in, and Empower 150? But I want very brief, because I'm just going to run through the data, and then we'll come back to this question.
So I'm more comfortable with Keytruda thing, not with the checkmate trials.
Okay.
So I'll talk largely about Keytruda, and I have a problem with Empower because it compulsorily require Avastin, so I'm not a great fan of that. So I do get PDL1 done appropriately in all the patients. By appropriately, I mean I get a 22C3 CPS code done in all. I take a call on who should be treated with chemotherapy alone, or a immunotherapy alone, or a combination of immunotherapy plus chemotherapy. I think 80% in this particular case seems to suggest that the IO is going to be the major drug partner. But in this particular case, yes. But if I have a high volume of a disease and I want almost certain of as good response as possible, then I don't just factor in 50%, 60%, 70%. I don't mind giving them a combination if response and the rapidity of response is the major point in mind. If somebody is 65, a large volume disease, but the rapidity of response is not required, 2 bone mets here, 1 liver met here, 2, 3 other here, then I think I'm happy to use immunotherapy alone. But if I need a response, I bring in chemo.
Okay, so I think one good point, two things that you clearly said was you are favoring pembrolizumab, so you actually do the companion diagnostic for that. And the second you were talking about, and I will come back to Dr. Bapna for that in a minute, but you were talking about actually assessing the volume of disease, and I'm guessing you're talking about using combination or not in a second. What I'll do is I'll rush through the data that's available to us when you sit in the clinic, and then we'll come back to the key questions that we should be talking about that. But as I rush through, I will take comments from my panel, maybe Dr. Mohan Menon next, but I'll go through the slides and then talk about it. So this is Keynote 024, obviously, which was studied only in PDL1 more than 50%. Our patient actually is 80%, so he certainly fits into that. We showed chemo versus IO. There was a clear benefit, and more or less in the entire group, including obviously former and current smokers. I don't understand how current and former can be very different, but that's what it was. And it showed that patients with PS 0 and 1 in squam and non-squam, young or old, actually seem to benefit from this combination. So if I ask Dr. Mohan Menon, maybe what did you make of Keynote 024? And do you think, and I think Amit was alluding to that, but this is the pointed question. Do you think if you had a patient with high volume disease, my patient was not high volume, but if you had a patient with high volume with multiple bone, liver, symptomatic, a bit suffering with effusion, would you consider single line immunotherapy in a patient like that? And I think it's a bit theoretical because the performance status would drop, but let's presume for the sake of argument is PS1 with large volume disease, rapid onset. Dr. Mohan Menon.
Yeah, I think, can you hear me?
Yes, sir.
The issue here is that I was going to bring up the issue of performance status, but you already raised that point, that you want to say that someone manages to maintain a good performance status. And the answer to your question is no. And the reason for that is that at this point, we do not know how much chemotherapy adds to or subtracts from your immune system. And being somebody who was around before IO started, I guess that's most of us, and probably even at a time when chemotherapy just was beginning, I think chemotherapy certainly still has to play a role, especially, as you said, in people who have high volume disease. The issue is, will it subtract from your immune system? At this point, there's no data that it does that. So I would definitely give chemotherapy. And I am still not ready to walk away from chemotherapy in any patient as yet.
Well, even this patient who's fairly okay, he's got 4 liver mets, a small lung mass, PS01, not
Yes.
in crisis. Even there, PDL1 80%, you would consider adding chemotherapy
Yes.
in this patient too. Okay, very important point. You make a great point. I think I do think this is debatable. I don't know, Dr. Joshi, do you agree? And if you do, please make your comments, and then I can ask anybody else in the panel to disagree if there's some disagreement with that.
So
Dr. Joshi?
Yeah, Nitesh, I'll make a point. A bad tumor marker could be as good as a bad drug. I'm not sure about PDL1. If you say from evolve from keynote 024 down up to subsequent IO trials, if you see the magnitude of the response was probably you could debate, but all the patients, even if those patients who had PDL1 no expressions or undetectable, do got benefit with immunotherapy. So I'm not very sure about, we are still not clear about PDL1 as such, and the intensity of the expression would dictate my response.
Ashish,
So I agree with Dr. Menon here is that I would, sorry.
do you not feel that PDL1 less than 1 to 50 and more than 50 are 3 distinct groups, especially done on a companion?
They do form a distinct group, but as far as the trial studies are concerned, and if you see the data down the line as well, even those patients with a less PDL1 expression do get benefit. But one, that would be a determinant of using whether you want to use monotherapy or no. So somebody who's got a PDL expression as high, you would stick to monotherapy. But again, since we do not have our own data, and my personal experience has not been very great with monotherapy with IO, I still tend to use, even with a PDL overexpressing tumors, a combination of chemo with IO.
Okay, so in my panel of Vikas Talreja, Nilesh, Mohan, Menon, Ashish, Joshi, Dr. Bapna, Amit, and Vivek Agarwal, have 2 people who would like to use in more than 80% low volume, good performance status, chemotherapy upfront. Clearly, Dr. Mohan Menon mentioned because he's still wondering what is the impact of that. And Ashish felt because he doesn't trust PDL1 or maybe PDL1 in the setup that we're doing. Is there anybody who wants to debate that in our panel?
So if we dissect, Nitesh, the progression-free survival and overall survival in the PDL1 less than 1%, the survival in patients was much less when the chemotherapy, the pembro alone was used. So in these patients from less than 1 or 1 to 49, it's mandatory to use the combination chemotherapy, and more than 50%, I think it is entirely the discretion of the treating physician.
So what's your discretion, sir? So what's your discretion?
If you talk to me about your
more
case,
than 50, sir. More than 50 performance rate
yeah,
is good,
so this
low
case,
disease.
you said that his performance status is TS1.
Yes, sir.
And is quite preserved. So
yes,
it is very clear that, I'll be using the single agent pembrolizumab based on the data of published data.
Okay, anybody else want to favor Dr. Bapna's view? Amit, what would you do?
I just wanted to make a comment. So I think this is an ongoing debate. What we know for sure is that there is an incremental benefit as the PDL1 goes higher. There's no doubt about that. I would prefer to use a combination of IO with chemotherapy when I'm looking for a faster response, even in a patient who's got a PDL1 expression of more than 50%. But otherwise, like in the case that you have shown us today, patient is stable, limited to metastasis. We're not really very keen to have a very rapid response. I would be very comfortable using a single agent pembrolizumab.
Okay, I have 2 versus 2. Any one comment will tilt it towards 3 versus 2.
I will agree with Dr. Nilesh, sir.
Oh, wow. Okay,
Yeah,
so we have 3 versus 2.
Agree, sir, that
Nitesh, I answered the question in the morning. The next trial,
Vivek, Vivek,
323 and 363 will help you.
We will
Remember
talk about
those.
3 to 3 in the end. Vivek, Agarwal.
yeah, so that was what I was saying, that there is no harm in trying with 1 or 2 cycles of immunotherapy alone, because if the patient's PS is preserved, then you can intervene with chemotherapy if you are not feeling that the response is not there.
Okay. I think I buy all your points. What I'm hearing so far is that there is a doubt in our minds if we can use PDL1 and if we can use data of even more than 50 in all comers. I think we're all judicious enough to know that when we feel that the patient is at risk, we will add chemotherapy. But if not, single agent immunotherapy could be used, would not be incorrect. And I think this kind of comes a little bit from 189, although the best trial would be IO CT versus IO alone in more than 50%. And this obviously again was a positive trial, and the positivity went up as more than as the PDL1 went up. So I do think that PDL1 done properly can be a useful marker. Can I get Amit Agarwal to comment on 189, please?
What do you want? Sorry, Nitesh, I missed the point.
I'm saying there were two questions that are coming in the previous discussion. One was about the robustness of PDL1 being a predictive marker, and I generally want your comments about 189, about the role of IO versus IO chemotherapy combination versus chemotherapy alone, especially low PDL1s. I think more high PDL1 of more than 50, we are getting comfortable with a single agent if the patient has some buffer time. We are not comfortable if the patient doesn't have buffer time. So I think that's clearer. But what about
That's the
PDL1
answer.
less than 50? Haji.
So if it is PDL1 less than 50, somebody who is absolutely not a candidate for chemotherapy at all, then you actually have a choice of not treating him or treating with Keytruda or whatever immunotherapy that you really prefer. I mean, these are chemotherapy
No,
ineligible.
I think I'm misguiding you. Sorry, Amit.
Yeah,
I'll say
but
this.
if somebody
I'll
is
say this.
chemotherapy eligible, then I think
Yes.
combination is the best answer. If you have a lowish PDL1 score, one should not be guided like a 48%, 49%, 40%. It's a variable spectrum.
What about less than one? What about less than one?
So
PDL1 less than
I
one.
tell the patient that, you know,
This
the
population.
element of benefit from the immunotherapy is going to be very, very close to zero, not going to be zero. It's their call. For example, I recently had a patient, I told him 2%, 3% possibility with a PDL1 score of zero. He wanted that. But in my own mind, I am not great fan of using immunotherapy as a major partner when your PDL1 scores are low. In this case, you talk about zero. So I'm not convinced about immunotherapy as a major drug here. The data suggests that there may be a small minuscule role. Um, in my own mind as a doctor, I'm not quite inclined, but I leave it to the patient. Most of my patients would say no.
So can I summarize that between chemotherapy and IO, if a patient we feel is higher burden, we'll do chemo IO. If a patient is 1 to 49, we may be tempted. If the patient is less than 1, then I think we'd be tempted in staying away unless actually we're being pushed in every direction. If my panel has a comment, anything different from what I said, please raise that.
Only it is in the less than 1% that we have 62% 12-month survival. But in 1 to 49 and more than 49, it is 72 and 73% 1 year survival. So it doesn't make difference in 1 to 49 and more than 50. Or it's only in the less than 1% that survival goes down to just 62%.
So you're suggesting we should never use it in less than 1%?
No. It should be used, but there is a variable that all these diseases are not same. The less than 1 to 49 and more than 50.
Okay. So
we can use them as a different clinical entity altogether.
Okay, I'll start
in spite
with
of
Vivek.
using the best combination, the 1 year survival is 62% in less than 1%.
Okay, Vivek, I'll let you take this checkmate 227. I think this was a very interesting study because we have had a huge amount of issues with ipilimumab without having had it launched in India yet. Now that it will be launched in India, we really see whether the issues are genuine or not. So last 3 years, I've been hearing almost every panel saying ipilimumab is toxic. And every time I've asked how many patient experience have we had, we've had anything between 0 and 3. So I've had 3. So I touchwood did not have toxicity of ipilimumab any of those 3 patients. But we'll see this when it comes. This is reality. A patient who either is not chemo eligible for whatever reason, or more importantly, refuses to have chemotherapy. Let's talk about a patient says, I will die of psychological distress if I have chemotherapy, let's say that.
Yeah.
Would you consider IO-IO combination based on this data, which was very interesting? Please,
Yeah,
if
so
you
this
could
is
explain what it showed.
Yeah, so this is a very interesting data. And, sir, now when we have the spectrum of using so many IO molecules from pembrolizumab to atezolizumab, so, and now to only IO avoiding chemotherapy, and even the 9A data where you just give 2 cycles of chemotherapy. Again, regarding the toxicity part and the efficacy part, well, no personal experience. I have only used ipilimumab in one patient ever, and that was also a case of melanomas, and that was also some 3 years ago. But the data appears to be very good. The one thing that I really want to say, that when we are actually ordering the test, it is now with so many agents available, are we really deciding on the drug and then ordering the accompanying test, or are we first ordering an accompanying test and then deciding on the drug?
What do
So
you
with
do?
so many options, this is a
What
very
do you do,
interesting that
Vivek?
comes to me.
What do you do? What do
So
you do?
so I always, sir, order the test, and I have been ordering 2 to C3 only most of my times.
Okay.
So we are stuck with pembrolizumab only because the molecules are not available. But once they are available, this is one thing that really intrigues me, that what should be the practice, whether we should decide on the test first or whether we should decide on the drug first.
Let me ask that quick round to everybody. Test first or drug first? Vikas, test first or drug first?
I suppose every platform is similar except for the 142, and I believe we are well versed with 22C3. So test first
Come
and
on.
then
Yes, test. Just say it just in one line. Be very
perfect.
committal. Test first. Okay,
Test
test
first.
first.
Test
Okay,
first.
so and 22C3?
22C3.
Yeah.
22C3. Dr. Bapna?
Yeah, I'm little bit biased towards using Pembro, so I'll also go for IC
22C3.
22C3
Nilesh?
because
Since it's the only available drug in first line today, apart from Atizo, test first and Daco.
Okay, 22C3. Okay, again, Dr. Mohan Menon?
I agree.
Okay, and that leaves Amit Agarwal.
Same.
Okay, so I think what we are all saying is we are going to do 22C3. What we all, and I'm actually the next one who's saying that we'll do 22C3, and we're going to extrapolate on the rest till we get the drugs more easily available. But that already means that Pembro has a head start. And so if you really want to do IO, you could, but technically you should actually be retesting.
so
That's what,
basically, Nitesh, checkmate 227 and 9LA can be a preferred option for the patients who have been heavy smokers. So I think
and so heavy smokers you feel are better off by using a CTLA4 inhibitor? Is that what you're implying, or you're saying that nivolumab is a better drug?
so the checkmate 227 and only 9LA have shown its correlation with the status of the smoking. The 024 and
Yeah.
189 have not shown that the
Yeah,
smoking.
but is that because it's not studied, or do you think there's a benefit in the drug?
I don't know. There must be some correlation because these are the nivolumab and the IP based have shown definitely the good improvement in the patient who have been a smoker or the reformed smokers.
Amit, do you want to take? I know you already have a view on this. I'm asking you, Amit. Do you want to take smoking, TMV, and IPI and Nivo question?
See, this drug is not available. So when this drug will come, we will read about it. I mean,
Thank you.
this is a hypothetical discussion. I will refer a smoker to you on Monday. What would you do? You will give an ipilimumab from where? I mean, you gave 3, I gave 0. I mean, so this is a hypothetical discussion. When the drug will be here, then we will see.
Okay, so this was 024 concluding that an important question for further study is whether the addition of Pembro to PEM and platinum-based has greater efficacy than Pembro monotherapy in these patients. Without direct comparison, it leaves to the entire panel to decide. So basically, I'm still saying that the answer is not there, and I think that's what we said. Very interesting, the 9LA. I think Vivek mentioned that a while ago, but I'll let Dr. Bapna talk about 9LA, which essentially was a 2 cycles of chemotherapy thrown in within Nivo IPI at the upfront. and compared to chemotherapy followed by PEM maintenance if it is allowed. A fair amount of smokers in this, and that's why I'm asking Dr. Bapna to take that, and a predominant non-squamous. So fair amount of smokers with predominant non-squamous, but do note that a good 20% had CNS metastasis. And I think that's my area I'm watching carefully, the role of IPI when we're talking about brain metastasis and immunotherapy. But we had a majority of patients who were less than 50 in a PDL1 scoring, and we saw that there was a good advantage in OS and majority on the left side. But I'll let Dr. Bapna conclude of what he made out of 9LA.
So this is also a very good trial actually, and whatever trials we have discussed, 024, 18 time, or checkmate 227 or 9LA, basically we need to decide amongst ourselves, which is the preferred option, which is the potential alternative, which is the acceptable alternative, and the appropriate alternative. So this 9LA will come in not in preferred option, but will come in one of those alternatives.
Yeah, so
because these all have approval of the federal bodies after all.
Okay. So that if you want to do it, you're allowed to do it now. Okay.
Yeah.
So this is the graphs for the different PDL1 and their conclusion. I think Dr. Bapna has concluded better. Empower 150. Any takers for this? Maybe Ashish, do you want to take Empower 150 and tell me what you make of it?
So one of the conspicuous point on Empower 140 was it raised another tumor marker, or rather predictive marker, because they studied effector T cell gene expression in wild type of patients, and they found that there is a conspicuous difference between the efficacy of atezolizumab in patients who had those expression. So maybe it could be one of the markers down the pipeline. We still don't have it in our routine assay, but that is one of the interesting point there as far as Empower 150 is concerned. Another important point is, of course, this is a combination of 4 drugs together.
Can I pause you for
Sure,
1 second?
Sure.
Are you implying that till you can do this, you will not use Empower 150?
I'm not saying so. It's just that we are debating the. You requested me to mention the important points in the study. So this is one of the points which I thought was relevant.
Please carry on.
And the second important is obviously the 4-drug combo upfront, ABCP. Not very particularly fond of it, and for a stage 4 NSCLC, though the toxicity of ABCP versus 3-drug was similar, I would be keeping it reserved for only very specific group of patients. So not very keen on using combination of bevacizumab plus atezolizumab.
Can I add one, Nitesh?
Sure.
Nitesh, can I add one point?
Please,
so out of these all trials which you mentioned in your second slide, I think this is the one trial which has a lot of flaws in the designing itself. As Ashish mentioned that the biomarker of T effector gene cell expression, this was used only in this trial, and it has not been reproduced by any of the trial, and it is out now. So
so Dr. Bapna, and then actually I'll ask Dr. Mohan Menon's opinion on this. Do you feel that if you have a patient with PDL1 80%, and considering that for various reasons, that person can get atezolizumab at a cheaper cost, would you use this drug without a TEF group and without PDL1 on other understanding? And he's done it on 2263C3, he's 80%. Would you, the fact that you don't have TEF, would you be comfortable using this drug in this population? Dr. Bapna first, then Dr. Mohan Menon.
No, I don't think the test is now validated in any of the lab. Nobody is doing it.
Nobody's doing
Besides, it was done in this trial. So it is, I'll be very skeptical in using this. I am Power 150. I'm very clear I'm not going to use it because of the flaws in the designing of the trial. And the third arm is absolutely missing. The data was never published. And you never know whether the effect was because of the bevacizumab, which we have added in this trial. So I'm not really.
Dr. Mohan Menon, can you give me a bit of a detailed answer of, do you feel comfortable? I think it's not only about Empower, but it is about what was being raised before. Do we feel comfortable about testing with one companion diagnostic and actually using it for some other immunotherapy? Dr. Mohan Menon.
I think it's a philosophical question. You have groups of companies Merck being probably the leading one, which advocates for PDL1. Now, PDL1 is probably the best test we have currently to evaluate the likelihood of somebody responding. But it's an imperfect marker. And that is precisely the point of a bunch of other companies, Bristol Myers being the contrapoint to that. And another one is Roche. Roche's point is also that the study was done for patients with all PDL1s. Now, midway during the study, they came up with the STEP study evaluation. Now, Roche is one of the best companies as far as diagnostics is concerned. They have a separate diagnostics division. So, I would certainly like to know more about it. Now, with regards to the issue of does it matter whether PDL1 is more expressed in these group of patients? As far as the study is concerned, it didn't matter. Would you think that they would respond better with the likelihood of a response because of PDL1? Probably, based on what we know.
Okay, thank you very much. I'm now going to try and close this because I have to go to small cell if I have time permits. Otherwise, we'll close this early. But I'll go to Vikas first, then Nilesh, then we'll go one by one. We'll let Vikas, you take the first three: adenocarcinoma, non-smoker, PDL1 less than 1, more than 1, more than 50. What would you do? Immunotherapy, patient wants, cost is not a concern.
Sir, for the Empower one, I think so. The trial, the topic, I am the power and I can do anything. So that's why the I am power. And ABCP regimen they have choose because any bullshit can be possible. That's my take for that.
So Vikas has put it correctly.
And I suppose nobody's listening to us right now.
Yeah, they are.
Except
Please
those.
mind your language. I'm the moderator. You can't use that language.
I sincerely
apologize for that.
apologize. I sincerely.
Truth is always harsh.
Okay, but Vikas,
Yes.
Adenocarcinoma, first line option, cost not a concern. Patient is insisting on immunotherapy. PDL1 less than 1, more than 1, more than 50. What would you do?
So more than 50, definitely single agent Pembro. More than 1, Pembro plus minus chemotherapy after discussion. Less than 1, again chemo vis-a-vis the data for checkmate, the IO combination. I'm slightly inclined for it because it shows the curves are separative. And similarly is the smoker. It doesn't.
No. Wait. That question goes to Nilesh.
Perfect.
Okay, but I'm going to also put in the caveat of everything we discussed about the volume of disease and so on and so on. And I do think that when we're thinking, we will also think about second line nivolumab data when we're thinking of less than 150. Okay, Nilesh, over to you. And we're talking about smokers now or reformed, PDL1 less than 1, more than 1, and more than 50.
So I'll put it the other way. Essentially, for non-smokers, we know that the single agent IOs have not done very well, and this is especially true even for the Nivo AP combination. So definitely that is a place where I would not use it. And in non-smokers, I would prefer to use a combo of chemotherapy with an IO. In patients who are smokers, I think most groups have shown to have benefit, and the classification, as Vikas has mentioned, remains the same. So for EP and Nivo, non-smokers and liver metastasis have both not done well, and this probably is a group of patients who I will not use this combination, although it's theoretical since the drug is not there now. And you mentioned brain metastasis. I think most of the trials have had controlled brain metastasis post-irradiation at their point of entry. And among others, pembrolizumab has shown to have a response in patients with brain metastasis. So in that situation, Pembro with a combo of chemo would be my choice.
Okay, Dr. Mohan Menon, squamous, do you do anything differently?
Apart from avoiding bevacizumab, probably more or less the same.
Okay. Ashish, what about you for a combination adeno-squam? So this is not an adeno, this is not a squam. I'll tell you a real life situation today. Sewanti, do I have 5 minutes extra or do I have to shut shop very rapidly?
I think we have three minutes. We have 3 minutes.
Okay, so
Nitesh, so if you can cover small cell in 4-5 slides, that would be great, so that
okay,
we can do justice to
I
that.
think we had some discussion, so I will
Yes, excellent discussion
go
so far.
straight. We'll go straight to small cell. Basic question. There is a lot of data, but the basic question is: are you bought in? Yes, no, who, and when not. So I'll go to skip this because I think we have had, and I'll come straight to this, and I'll start with Amit Agarwal, then Vivek Agarwal. Small cell lung cancer. Do you believe it's prime time? Yes, no, and for whom, and when never to do it? Amit?
So extensive stage for, I mean,
Extensive stage. Yeah, extensive
the
stage.
data is there to even suggest an overall survivor, but the quantum of benefit is too small. So I'm not sold to immunotherapy in extensive stage small cell. We discuss if the patient can afford it and if they appreciate the small, tiny, minuscule benefit, fine for them. But as a doctor, I'm not sold for it.
TMB high? Still the same point?
So there is data on Keynote that TMB high matters. There's the data on other drug that TMB high doesn't matter. Each company is trying to find a molecule marker to sell. But I'm not sold for the drug as such. You divide the tumor into TMB high and TMB low, then you have to make your statistical significance of 0.05 divided by 2. That makes it 0.025. That's called Bernoulli's equation. All subgroup analysis that you're talking about are fraught with the fact that you keep on dividing the total group into multiple sections and then you don't divide the statistical significance. Not so.
Okay. Vivek Agarwal, are you sold or not sold? And
Yes, I would prefer the combination of immunotherapy with chemotherapy, sir. I have not had experience first line with Nivo, Durvalumab or Pembrolizumab, but I have had 6-7 patients where I had started Atezo plus Etopocarbo. And my personal experience is that most of these patients, I think 4 of them went into CR and they have been doing well. So my personal experience.
Okay. What about
Really
Nilesh
good.
and
Although the
Ashish?
data, as Amit mentioned, does show a minuscule benefit, but I'm looking forward to having more experience in it because the experience so far has been really good.
Okay, last 2 questions, Nilesh and Ashish. Can you tell me when A, you're sold or not sold, and when you would never use immuno in a small cell?
So no, I'm not sold because the benefit, at least in the OS, is 12 months versus 10 or 11 months. It's not for everybody. But I will discuss this option of all patients. I'm again also not able to distinguish a particular group of patients who will actually additionally benefit from the addition of immunotherapy. There are no real markers in that point.
Okay, and what about Ashish? Ashish, when not?
Yeah,
when
again,
you would say this is a bad idea?
Yeah, so I'm not sold for sure, but we have now 4 trials which showing a PFS benefit, minuscule OS benefit. I tend to discuss the option with the patient. Well, if cost not constrained, I tend to use it. I've used atezolizumab for 2 of my patients, but the responses, of course, have not been very exciting.
Okay, so I'll give my last comment and then I'll say thank you. I am essentially sold because I do think the benefit is minimum, but that minimum benefit I think is meaningful in this group. I am worried about some of these patients who need high doses of steroids, especially the one with multiple brain mets. And that's where I feel that if we start to tease that difference out, we may start seeing benefit because a lot of small cell patients, especially of mine, as Amish knows, are on steroids. So with that, I'll hand it over back to the organizers. Thank you very much. And I think this was great fun. Thank you.
Thank you, Nitesh. Yeah, wonderful.
Thank you so much, everyone. I now request Dr. Sewanti Limaye, medical oncologist from Mumbai, to please give her expertise and also to moderate the question and answer section.
Thank you so much. I think I have 4 minutes, so I'm going to keep it very, very short and quick. So in preparation for today's meeting, I actually spoke to 4 of my thoracic oncology seniors in the US, people who I've worked with, so that I could get their idea as well. And it was great, seeing and hearing Nitesh's moderation, the expert comments from all the panelists, wonderful. So some of the notes that I've taken through the moderation. So about 50%, we said we were more comfortable looking at Keynote 024, but even more comfortable offering keynote 189. So chemo plus pembro is the writing on the wall, but some differences from the experts abroad. Keynote 024, above 50% if you have a good PDL1 that you can rely on, and you don't have a high disease burden, which means you don't have liver mets specifically, then you could prepare the patient and in an open dialogue, consider starting pembrolizumab, especially if the TMB was high and there was no STK11 mutation found on next generation sequencing. So just some expert thoughts. For high disease burden, obviously it's all homogeneous, keynote 189. Empower 150 is still a question mark, like just everybody said that a 4-drug regimen was a no-no. The thoughts were if there was a patient with a driver mutation, and the driver mutation that we have all checked here and we have data on are EGFR and ALK. We don't have ROS1, we don't have other driver mutations. So if you have a patient who is a never smoker, who has none of these classic 3 mutations, but has other driver mutations, you know that that patient could be a poor performer. So let's say exon 20 insertion, EGFR exon 20 insertion, again on controversy, but that's a patient where one could think of Empower 150. That's a food for thought. Less than 1% PDL1, that's a space where Ipi-Nivo, which is Checkmate 227 and Checkmate 9LA, is being experimented or applied. Mostly there are certain centers worldwide that are more prone to using the Checkmate regimen than the others. And if the disease burden is high, the onus is to start with 9LA so that you give a couple of cycles of chemotherapy so that the separation of curves happen appropriately. One of the questions asked was test first or drug first. We'll answer that in a second. Lastly, about small cell lung cancer. So we said Caspian and Empower 133. These are the 2 regimens to follow. The keynote and the EORTC with the Pembro and Nivo lags behind. We don't have the OS data. So we sit back on that. Liver mets, brain mets are poor performers, and we need to use chemotherapy when we are giving it. And delay IO in small cell when there is paraneoplastic syndrome. That's one take-home message. And lastly, we had a little fun this morning. We were asked to figure out what was keynote 346 and keynote 323. And all of us got reading and searching it on, I did. I searched it on twitter.com. So
You're still laughing.
Amit Agarwal,
No.
35 minutes of my laughing goes to you. And
I want to
that
ask that question. But I want to ask that question.
On that note, I end my
design 323. What would you design that as?
That was crazy. So 35 minutes, I laughed at it. Last question, one question that was there, which I thought was very provocative. Do we call a 3-year disease-free survival or a 5-year disease-free survival cure? Are we ready to call it cure? So any thoughts on that would be welcome. With that, I think we're all out of time and we'll have to move on. Oh, we have some questions. Amish, do you want me to ask the questions or do we keep it for later?
No, Sewanti, I think we can take 3-4 questions.
Okay. So to begin with, Amish asked this question, are we ready to call it cure?
We can call it operational cure.
Bapna sir, what would you say?
No, not. It's, I think, too early to call, if at all, it will be called the functional cure, but maybe the longer follow-up is required. Amish?
Nitesh,
No, not cure. Not cure. This will evolve. There's no way it will get cured.
Yeah. So it's a palliative setting.
Sir, do you have a thought on this?
I'm still hopeful that there will be cure, but right now I don't see that we can call this as cure. And primarily because with all the TKIs, we've seen that people ultimately have progressive disease because some resistant mechanism develops, and that is likely to be with IO as well.
Sewanti, can I add something to what Parekh sir has said?
Please.
So if you see the curve of TKI is always going down the slope. You will never find TKI of any drug curve which is plateauing. Well, why I raise this point, IO and IO, especially if you see MRCC or if you see lung cancer, the graph are plateauing beyond 2.5, 3 years. That's why I was tempted to ask this question that if PFS crosses 5 years, would we call it a cure? But we can move on. That was my thought process of that.
So I'll just give my thoughts. I am tempted to call it cure. What else do you say when the patient stops therapy, goes away from your clinic, doesn't want to come back, and survivorship issues come in? It is like cure. So I think we need to revisit that definition. Go on to the next question. So I guess we are asking test first or drug first. Any takers? Dr. Mohan Menon, what do you think?
I stand with by what I said earlier.
Yeah.
That is, at this point, we have a limited number of tests available. Just because a test is negative doesn't necessarily mean that you would not use a PD-L1 agent, because as I said earlier, it's an imperfect test.
Yeah.
If you have somebody who can afford it and somebody who you feel would benefit from it, you don't use pembrolizumab, you can use nivolumab, because in that group of patients, there is good data that you can use that. So there's a way around it.
Yeah, excellent. So Dr. Ashish Joshi, thoughts on this?
Yeah, as I mentioned to you that PD-L1, bad marker could be as bad as a bad drug. I'm not saying PD-L1 is a bad marker, but it's an imperfect marker. So I would have my reserves on that. I agree with Dr. Menon here that almost all group of patients do get benefit. But for choosing monotherapy in elderly patients with a poor performance status, I would stick with my neck out with 2 PD-L1. If it's very high, I will use monotherapy. Otherwise, it's chemo, mono, IO combination for most of my patients.
Bapna, sir, you would also use combination?
Combination, it entirely will depend on the...
Stratify based on the PD-L1 status. Do you get your PD-L1 first or do you decide on the drug first?
No, I'll definitely go for PD-L1 because there is abundant data is available to us. So there is nothing left to the imagination.
Excellent. Nilesh, I know you were there.
Yeah, so test first for sure. And the day I have all 3 drugs available and all 3 tests easily available, I'll probably do the whole panel.
Great, thank you. So my next question here, one of the questions I asked was, when would you use monotherapy? Anyone can take it.
This can be the last question, Sewanti.
Sure.
So this will be a group of patients who have more than PD-L1 more than 50%, very well preserved, and doesn't require the tumor reduction very fast. So this is a group of patients where you can start the monotherapy.
Excellent. Thank you, sir. So these were the thoughts actually. The international experts also had weighed in that Keynote 024 could be offered easily for any patient who had a PD-L1 status above 50%. But we had to keep open communication. And I think Vivek had described how he would look for 2 cycles and response to therapy. And if there wasn't a response, they would add chemotherapy in a patient who was in good performance status. So again, open communication and close follow-up. And you do it in collaboration with the patient, wherein you're holding back chemotherapy, but you're really looking out for symptoms. And if there is a delay in capturing the symptoms or delay in recovery, that's when the chemotherapy needs to be added for such a patient. So with that, I think we are all out of time. I see Dr. Deshpande sir here with us this evening, and I'll hand over the meeting back to Amish to welcome.
Yeah, thank you, Sewanti. And before Kashish, we move forward. Am I audible?
Yes.
Okay. This particular panel, with the moderator, with the panelist, and with the expert, was the idea of PCP. And I must congratulate all the 3 components that they exactly delivered what probably we had envisioned when we started this PCP series. And I sincerely want to thank and congratulate all of them. With that, Kashish, we can move to the next topic.